All right, here we go. Chapter 9, Part 3, the gathering of vital signs. This is going to be part of your patient assessment. This is going to be an important part of your patient assessment. Um, Depending on patient condition, most of the time will depend on how many sets of vital signs we're looking to take and how often we're looking to take them, because one set of vital signs all by itself isn't really altogether that useful for us. When we check our patient's vital signs, generally the first set we take is called a baseline set of vital signs. That's our jumping off point. We don't know what our patient's blood pressure is normally, what their respiratory rate is normally, and so on right down the line when we start talking about what the actual vital signs are. And without taking subsequent sets to follow up, then we don't really have any idea what is, quote, normal for this patient, what their condition is actually doing, and whether or not they are remaining stable or becoming unstable. Now, those subsequent sets of vital signs are called trending. We're trying to identify, is their blood pressure holding and staying where it should be? Is their heart rate increasing or decreasing? Is their respiratory rate increasing or decreasing? Add to that now, like when we talked in pharmacology about how before and after we give a medicine, we need to check our patient's vital signs and then recheck our patient's vital signs to see, was our treatment successful? Was it doing what we expected to do inside the body? And so on right down the line. Vital signs are pretty much almost what we would consider an internal look at what's going on inside the patient. So far, we've only talked about things that were pretty much external, right? You know, most of what we've been talking about so far with our primary assessment, a lot of it until we get to treating problems in the primary assessment, are things we're pretty much just watching and not really, getting a whole lot of measurement out of. Blood pressures are actually measuring those things that we're looking at. So here are your vital signs, that top bullet point. We're going to talk pulse, respiration, blood pressure, skin temperature and condition, and pupil response to light. We will probably cruise right through documentation on the ePCR, and you'll hear me on my soapbox a little bit when we get to use of monitoring devices for blood pressure and pulse and O2 saturation and all that. Really what we're going to concentrate on and what we're going to work on some more today in class is just getting good at obtaining these vital signs. And I'm going to pause you guys for just a moment because I have to answer someone in the chat, and I'll be right back. All right, I am back. So like I said, vital signs are outward signs of what is going on inside of our patient right that very minute. Our blood pressure is going to tell us how well our patient is supplying blood to the periphery of their body, how well their vascular tone is maintaining itself. It gives us a whole wealth of information when we step back and look at it. The same thing when we measure a patient's pulse, when we look and see what is that pulse rate, rhythm, and quality, because we're always checking pretty much the same things when it comes to that. It's very important, as I said already, in identifying patient trends and noticing different possible conditions. That video I played for you guys just a couple minutes ago talked about some of the different things you'll notice right off the bat, and especially when checking a set of vital signs on your patient, that will tell us what different kind of shock a patient might be in. We'll also start figuring out sort of what is baseline, quote, normal for a patient of particular age groups or health statuses, and it will help us sort of come to how severely sick or injured they may be and help us identify some treatment priorities that maybe aren't apparent just by looking at our patient. So let's talk pulse. Somebody tell me how we're going to measure a patient's pulse.
By taking with the stethoscope?
With the radial artery?
Yeah, so radial artery, anywhere there is an artery passing over a bone, particularly near the surface or a structure that it can be compressed against, think maybe now carotid artery, we can obtain a pulse. We're going to take our fingers, if we're talking radial artery, on the thumb side of the wrist, and you'll be able to move your fingers around a little bit and compress that radial artery against the bones of the forearm or the bones of the wrist, and you will be able to feel your patient's heartbeat. We're going to count that heartbeat for 15 seconds and multiply it by 4 to come up with how many beats per minute our patient has right now. One change to that might be if our patient is extremely tachycardic or extremely bradycardic. If our patient has a really, really high heart rate or a really, really slow heart rate, we may actually count beats for that entire minute. Because think of it this way, if we're going to multiply by 4 to come up with what their average heart rate is, right? Every beat that we're off corresponds to 4 beats at the end of that minute. So someone's heart rate could be so difficult to count because it's so fast that we don't get an accurate number when we multiply out that number times 4 to come up with how many beats per minute their heart is beating. So if their heart rate is really, really fast or their heart rate is really, really slow, we're going to go ahead and count for that whole entire minute. Now, we've been talking radial artery, and that's going to work great for people who are conscious and alert and speaking to us. Excuse me. Conscious people don't generally really love the idea of us coming up and jamming 2 fingers into the side of their neck to check their carotid pulse. If my patient is unresponsive, however, well, unresponsive people don't complain. So when we check an unresponsive patient's pulse, we're actually going to reach down with one hand and check a radial pulse and reach up with our other hand and check a carotid pulse, and we're going to compare the two. What things do you think I'm comparing when I touch a carotid and a radial pulse at the same time?
Strength
Strong
of the
there?
pulse.
So I heard strength of the pulse. Malachi, what were you saying?
Same thing.
Okay. Yeah,
Same, if it's the same beats at the same time.
yeah, you guys are putting this together. Good. I'm comparing those same things, rate, rhythm, and quality. Because my patient who now let's say is in shock and they are very hypotensive, so their blood pressure is really low, and I reach down and I check a pulse on that radial artery, it might be really, really weak. If their blood pressure is low enough, it might be completely absent. And I have to reach up and check a carotid pulse to make sure they even still have one. It takes a blood pressure somewhere around at least 90 for the heart to pump blood all the way out to the periphery of our bodies. So their blood pressure has to be over 90 to have a radial pulse. And then as we move closer to the midline, as we get more central on the body, say we were checking femoral pulses. Now, if a patient has no radial pulse and we reach down and we compress that femoral artery against the bones in the pelvis, they may only have a blood pressure of around 70 or 80, but we still have a femoral pulse. And then the further up we go, we get to the carotid arteries. Now we're really close to the heart, really close to the midline. And that patient might only have a blood pressure of, say, 60 systolic, but still have a carotid pulse. So the further in and the closer we have to get to the body to feel a pulse appropriately, we get from peripheral pulses, which is your radial pulse, or your dorsalis pedal pulse on the dorsal side of the foot, to femoral, to carotid. The closer in we get, the lower your patient's blood pressure is. And that will start pointing us down the road of, all right, my patient's very hypotensive, they're probably tachycardic, and it starts sort of setting our treatment priorities and identifying sick versus not sick. Now, how do we check a respiratory rate on our patient?
Looking for the
Without,
rise and fall
without,
of the chest cavity.
Okay, yeah, looking for rise and fall of the chest. We're going to count that for that same 15 seconds. Now remember the little trick I taught you. When you're checking your patient's pulse, hold your fingers there for 15 seconds, count your pulse, multiply it by 4, come up with that number, and then don't let their hand go. Because the minute somebody realizes that we're starting to check the way that they're breathing, they change the way that they're breathing. They slow down, maybe they hold their breath a little bit. So act like you're still checking their pulse. Count how many times their chest goes up and down in the next 15 seconds. Multiply that number by 4. And now you have your heart rate and your respiratory rate. Next, we're going to get down to skin color, temperature, and condition, and then that pesky little thing called capillary refill. Skin color, temperature, and condition is going to tell us a great deal about our patient's perfusion status. It is going to tell us how well they are moving oxygenated blood around their body. The little vasculature in the patient's skin, way out at the periphery, when that epinephrine gets released because our patient's been exposed to something like anaphylaxis or hypovolemic shock, is going to constrict. And when it constricts, it's going to change our patient's skin color, temperature, and condition. People, when they're generally healthy, well perfused, good blood pressure, good pulse, good respiratory rate, they're going to be pink, warm, and dry. When we start seeing changes to our patient's skin color, temperature, and condition, we can say that their perfusion status is questionable at best. It could be a cardiac problem, so a pulse problem. It could be a respiratory problem or a respiration problem, either respiration, ventilation, you name it, or it could be a combination of the two. These are just things that are starting to help us build our case a little bit. How do we check our patient's pupillary reaction? I'm going to come back to capillary refill.
With pen light.
Yeah, we take our pen light and we cover one eye. Eyes will operate sympathetically with each other. We'll talk at length about that when we talk injury to the eyes. But we need to cover one eye. We want to make sure we're not in a very brightly lit area. And we take our pen light, we come in from the side, we shine it in the pupil, and we bring it back out. And what we're looking for is that pupil to constrict when the light hits it, and then dilate when we remove the light from it. We would note those pupils as equal round and reactive to light at that point, because that's the reaction we expect. Now, any differing from that, we would also go and check the second eye. But anything that changes, if the pupil isn't equal, if it isn't round, if it isn't reacting appropriately, are something that we're going to want to take note of. Most of the time when we see problems with our patient's pupillary reaction, we're talking some sort of insult to the central nervous system, whether it's from a head injury, whether it is from some sort of other mechanical trauma, or whether it is as a result of shock and now my pupils are really, really slow to respond because there's not enough blood left in the body for them to do what they're supposed to. Or it could be something as simple as like our overdose patient we talked about on Friday in pharmacology, who has really just turned off their central nervous system, and now the pupils are itty bitty teeny tiny and not really doing what they're supposed to as far as reaction goes when we check them. Getting on down to blood pressure, I put blood pressure and capillary refill sort of together. Blood pressure, we already know a pretty decent amount about. That systolic number is the pressure exerted on the insides of the patient's arteries during systole, when that left ventricle contracts and sends blood out through a pressure wave from the left ventricle into systemic circulation. That diastolic number, that's measuring the pressure that is still in this whole cardiac and vascular system when the heart is at diastole or relaxed. Different conditions will cause different changes in our patient's blood pressure. Think, pipes pumping fluid. All of those three things have to be working together in order for a patient to have and maintain an adequate blood pressure. And if there's any problem with either the pipes, the pump, or the fluid, your patient is going to have an issue with their blood pressure. And that brings us down to capillary refill. That's what we have left. That is when you reach down and you squeeze your patient's nail bed and it goes from pink to white. And then when you let it go, that white color disappears very, very quickly. If your patient is adequately perfused, because really perfusion leads to metabolism and metabolism leads to healthy patients. If your patient is adequately perfused, that capillary refill time should be less than 2 seconds. It should be very brisk and quick. This is a particularly handy tool for children more so than adults. We don't generally, if our patient's under, depending on what it told you in the book, it's normally either 1 or 3 years of age. We don't really do a whole lot of blood pressure monitoring on children. It's difficult to obtain. Kids are awful fidgety. As far as trying to remember what all the numbers are that are considered, quote, normal, it's difficult to shove all that amount of information into our brains. And if we just do that one very brief, very quick check of their capillary refill, it tells us that they are perfusing right down to the tips of their itty bitty little fingers, and they must have an adequate blood pressure. Now add that to the fact that we've checked skin color, temperature, and condition, and pupillary response, and checked their pulse rate, rhythm, and quality, and it gives us a pretty good case for their blood pressure being normal. So I already did this, baseline vital signs. That is a term you should become familiar with. When we get to Chapter 9, Part 4, we'll talk about baseline vital signs a whole awful lot. That's the first round. That is us getting a feel for what is normal for our patient or what is going on with our patient right now, because people don't generally call 911 when they're having a normal, healthy day. Those trends are super important. Like I said, one set of vital signs doesn't really give us a whole lot of information, because let's say we provided some treatment to this patient. We would want to know if they were getting better, right?
Right.
Our patient that was in anaphylaxis when we showed up and had terrible rate, rhythm, and quality of their breathing, and had an extremely rapid pulse and next to no palpable blood pressure, barely could feel it in their radial arteries because their blood pressure was so low, we're going to give them epinephrine. And when we give them epinephrine, unless we check a further set of vital signs and try and establish that trend of how their condition is going, we wouldn't know whether they improved or they didn't. It's not like flicking a light switch. I mean, it's fast, but they don't get better like 2 seconds after you give that medicine. But we would start checking, all right, has the rate, rhythm, and quality of their breathing improved from my last set of vital signs? Has their blood pressure gone up since my last set of vital signs? And it's trending how our patient is doing. Are they getting better? Are they getting worse? Or are they just maintaining?
And we supposed to take those vitals every 5 minutes in an emergency situation, correct?
Yes, for a critical patient, it's going to be every 5 minutes. If you're on just sort of your average everyday transfer, we normally do them every 15 minutes because transfers are generally stable patients. But for all intents and purposes here in class, get used to saying that you're going to reassess your patient every 5 minutes, and that includes rechecking vital signs.
Roger.
So we talked pressure already. We talked systole and diastole. When we reach down and touch that radial artery, we are feeling that pressure wave. We are feeling systole. Every time that left ventricle squeezes and we have our fingers on our patient's wrist, that's actually what we're measuring. That's actually what we're feeling. Blood moving through those arteries caused by a pressure wave. So this gentleman right here is checking his patient's radial artery. Anywhere that an artery is close to the surface and close to a structure it can be compressed against, that's where we're going to check. The most common are going to be your radial artery, carotid artery, femoral artery, and then the dorsalis pedal on the dorsal side of the foot. The dorsalis pedal pulse is difficult to find. So I always advise people, if they reach down and they're checking circulation to their patient's feet and you manage to find their dorsalis pedal pulse, go ahead and mark it with a pen or a marker or something like that, so that way you know right where to touch the next time you go to look at that, because we're going to take subsequent sets. We're going to check again. Well, this is going to be filed in the common sense category. Our pulse rate is the number of beats per minute, and it varies among everyone. People that are in really great shape are going to have a lower pulse. Their heart and lungs don't need to work quite as fast as someone who's maybe not in the greatest of shape. So that's why we have a range. Normal pulse rate for an adult is considered to be between 60 and 100. Anything above 100 we'll call tachycardia. That means fast pulse, tachycardia. So over 100 is a rapid pulse. Anyone whose heart rate is below 60 is considered to be too slow. That is called a bradycardia. Brady meaning slow, cardia meaning pulse, so slow pulse rate. Now these are not absolutes. Remember, this is getting the whole picture. We're going to take this set of vital signs and use them to sort of put everything together. If your patient is a marathon runner who has a heart rate of below 60, don't freak out. They're not critically ill. They may have a resting heart rate somewhere in the 40s and be perfectly fine. So put all of these things together to form a story. These findings would be significant for your average human. So if we have a heart rate that is above 120 or below 50, we're going to call that a serious finding. Above 120, that's really too fast for blood to be circulating appropriately. And below 50, that's really considered to be too slow to adequately perfuse all the tissues and remove all of the waste products. Just make sure you're measuring everything together, because let's say you're providing standby for, a sporting event, and somebody comes running off the field and your initial pulse rate is, 122, because you're checking them out for, I don't know, some sort of injury, anything really. Well, they just ran from one side of a football field to the other to come over to me. So wait a minute before we sound the alarm. Use just a modicum of logic, right? If, somebody came running to you or was just involved in a car crash and we have all of that epinephrine coursing through their body, speeding their heart rate up, just because that initial heart rate is 120 doesn't mean it's time to panic. It means it's time to talk to the patient a little bit, figure out what's going on, and then check and see. Now, if the subsequent heart rates are 120 or faster than what it was, then it's time to start thinking, all right, this heart rate's a little too fast for my patient to be doing well. What are some other things that you can think of that might account for a heart rate outside of what we would consider normal? Fast, slow, doesn't matter to me. Come up with something.
Obesity?
Obesity, sure. So the heart has to work harder to pump blood when our patients are in the obese category, sure.
Age?
Age is another one. Yep, the heart might speed up a little bit for a while anyhow.
I have just a question too, about that. Last night with the reading and stuff, it said something about, or I read something where it said like shallow heartbeat. What does shallow necessarily mean in that situation? Or was that just like, is that like a wrong answer or something?
Was it a question on a quiz?
I think so, yeah. It was like it was like one of the answers to it, and I wasn't sure if it was the answer or not.
So a shallow heartbeat is probably not the answer you're looking for. Shallow is
Right.
normally when we're talking respirations.
Okay, because I just was like getting confused with that.
Yeah, if something, and remember, even on EMS testing, right, most of the time you're going to have two answers that are pretty logical, pretty close, and then you're going to have two answers that are most likely complete and total hogwash.
Hmm.
Uh, you can pretty much eliminate them down to a 50-50 and figure out sort of what they're digging at. And if they say something like the words don't make sense together, like shallow heart rate, now if they had said weak or thready,
Yeah.
then that's different. But shallow is not really one of the terms we would use for measurement of something like that. So
Yeah, I thought that. So I was just wanted to just double check with you.
no, that's great. If you got that, if you got to that all by yourself, it means you're reading these questions right. So we talked about what might make a patient's heart rate too fast. What are some things you can think of that might make a patient's heart rate slow down? I'll give you an easy
Medication?
one. How about cardiac arrest? Our patient's heart rate's going to slow right down to 0. Paul, was that you? Did you say medication?
Yeah.
Yeah, so there are certain kinds of medication, generally taken for blood pressure, that will slow a patient's heart rate way, way down. Generally, they will keep it sort of at or around 70, but that doesn't mean that maybe they didn't accidentally take too many of their pills. When we start talking about geriatric medicine, you'll see that polypharmacy or having a lot of meds becomes difficult sometimes for people that are a little advanced on the age scale, and they might accidentally take too many pills or accidentally take their significant other's medication that could have been double the prescribed dose that they were on just because the names looked familiar. So yeah, medications are overdose patients. They're generally going to have a slow everything, slow heart rate, slow respiratory rate. They're going to have a fairly slow pupillary reaction because that central nervous system that's supposed to speed things up and keep them alive and viable functioning human has been shut off. They have depressed their central nervous system to the point that things start slowing down and kind of crapping out a little bit. Rhythm's pretty easy. When we're looking at a patient's rhythm, we are talking, is there regular intervals between beats? Is it just nice and constant and marched out? That means the heart electric conductive system is functioning pretty good because it is sending off impulses to beat at regular impulses, and it doesn't seem like there is somebody playing a drum solo inside our patient's chest. Irregular would be when the intervals are not nice and regular and marched out like we would like them to be. That's going to point us towards a couple of different medical conditions. And really, it's just on us to identify, is the patient having a regular heart rate or an irregular heart rate? Some people live perfectly normal lives with a condition called atrial fibrillation, which will cause their heartbeat to be fairly irregular. It's not really that huge of a deal until, again, we start putting the whole picture together. And when we put that whole picture together and we see that, yes, they have somewhat of an irregular heart rate, but they're telling me that they have a history of well-controlled atrial fibrillation, and then their respiratory rate is fine, their mental status is fine, their blood pressure is fine. It starts sort of leading me down the path that, all right, this irregular heart rhythm maybe isn't what's causing them whatever problem that brought them to my attention that day, and I can start looking at some other things.
What is the cause of atrial fibrillation?
So it could be a lot of things. Sometimes it's age, sometimes it's just poor conditioning. The atria themselves really aren't super important, I guess I'll say, in the actual beating process of the heart. because they drain by gravity into the ventricles. So atrial fibrillation really isn't as big of a deal day to day, as long as it's well maintained with medicine, as something like ventricular fibrillation we talked about in CPR will cause our patient to go into cardiac arrest. A lot of times it's just a product of aging. The elderly, a lot of the times, will wind up with AFib in their history and an irregular heart rate. So we've talked rate, we've talked rhythm, now let's talk quality. Our pulse force is what we're speaking of when we're talking quality. How does that pulse actually feel when we reach down and touch that artery? It should be nice and strong. Sometimes it'll feel what we call thready, which is sort of weak, difficult to palpate, maybe difficult to find. When we have our fingers on it, sometimes it feels like it's there, sometimes it feels like it goes away. That can start pointing us towards some perfusion problems or some hypotension in our patient. All
The
right,
other day when they like a couple when Aileen checked my pulse, she said it wasn't really. She said it because she was pretty faint, which is not the right word to use probably because my pulse was fine. It's just you couldn't find it. But is faint the right word to use?
faint will work. It just means that it's not super strong. That could be something just as simple as, maybe you don't have particularly high blood pressure. I'm not sure if I took your blood pressure or not at all when we were working in our first sets of vital signs labs, but you may just not have a very high blood pressure.
And that's not a bad thing, right?
No, hypertension is a silent killer. So high blood pressure is not good for you.
Right, but low blood pressure isn't good for you either.
That's true, but most of the times when we talk low blood pressure, it's not sort of just low blood pressure all by itself. Your body will never, just
Right.
without sort of pathology, allow your blood pressure to get so low that it's negative for you.
And that's why you check all the vitals because not one can tell you, everything about your body.
That's it. And that's why every patient gets the same assessment. We are writing a story and we're doing our detective work and trying to figure out what it is that's going on with this human being right in front of us. And without all the information we can lay our fingers on, we really can't get a full story. So here we go. We have radial, brachial, and carotid. Somebody walk me through the process of checking a radial pulse.
You could check the one on your wrist, correct?
Thumb side of the wrist, and we are compressing that radial artery. Good. Somebody else give me the brachial pulse. Where are we going to check for that and how?
Inside of the upper arm, along the humerus.
You got it. We're going to compress that brachial artery against the humerus. You reach in with a couple of fingers between the bicep, and we'll actually be able to feel the pressure wave going through that brachial artery. This is particularly useful in children because that next one down on the list is difficult to check on them. And what is a carotid pulse?
In the neck.
In the neck, yeah. We're going to slide our fingers over into that little groove between the trachea and the musculature in the neck, and you should be able to feel a palpable pulse in your patient's carotid arteries. If you can't, that's a bad day for them. Remember the things we're checking: rate, rhythm, quality. We want to put all of these things together and write this patient's story. Anybody older than the age of 1, we're going to use a radial pulse, so we'll go ahead and check that pulse at the wrist. Under the age of 1, we're going to use the brachial pulse. Here's our brachial pulse. People under the age of 1 year old, we're going to place our fingers in the anterior upper portion of the arm between the biceps and triceps, just distal. So just a little bit further away than the patient's armpit or axilla. And that's where we're going to find our brachial pulse. And here's a nice picture of our carotid. We just slide right over from the midline and we find our carotid artery, and we just depress that a little bit and we will be able to feel our patient's carotid pulse. Now, never check both carotid pulses at the same time, because it's entirely possible that you're cutting off blood supply to your patient's brain. So we're always going to check on the side closest to us, because we don't want it to look on camera like we're strangling our patient, and only check one at a time. Here's what's considered our average resting heart rate. So adults and adolescents, 60 to 100 beats per minute. The younger our patient gets, the faster their heart rate will be. They don't have quite the same buildup and quite the same stores of blood and oxygen and all the other things that we have going in our favor. So their heart rate will be much, much faster. I mean, if you look at that neonate down at the bottom, let's talk a heart rate of almost 200. In an adult, would you be very, very concerned if you reached down and felt a heart rate of close to 200?
Yep. I
Me
would.
too. In a baby or someone who was just born, that's really not altogether that frightening. Kids are rate dependent, so they have to have that fast heart rate. If they don't, that actually means they're sicker than an adult. Then when we look at it with an adult, kids with bradycardia are about as sick as any patient you'll ever see. So we want to go ahead and make sure our kids do have those nice, rapid, strong pulses, because if they don't, they're going to almost immediately start to suffer from some perfusion problems, and we need to get on about our business of getting that all sorted out. So respirations is the act of breathing out. We are still measuring rate, rhythm, and quality. We're going to measure how many breaths per minute our patient takes. When we're classifying our patient's respiratory rate, as well as coming up with a number, because we're going to count how many respirations per minute, think of what it looks like. Does it look too slow? Does it look too fast? Or does it look decidedly normal? Our respiratory status and our respiratory cycle should be very, very unremarkable. What is considered normal for our adults is 12 to 20 breaths per minute. Things like age, sex, physical condition, and emotional state can influence respiratory rates. The better shape your patient is in, the slower their respiratory rate will be. If your patient is, running from a crazy chainsaw wielding murderer, we can expect their respiratory rate to be a bit faster. If the respiratory rate is above 24 or below 8, we're going to consider those very potentially serious findings. If our patient's respiratory rate is above 24 and their quality kind of stinks, so we're not getting enough of that chest wall motion to actually fill up the lungs appropriately, there's going to be less O2 available in those alveoli for gas exchange to take place. And we're going to see a patient who is in either respiratory distress or respiratory failure, and this problem is just going to potentiate off itself and continue to increase and make itself worse until we do something to intervene, whether it's respiratory distress and we just put them on some oxygen, 15 liters per minute with a non-rebreather mask, or it's respiratory failure because they've been battling this for longer than we know, and we have to ventilate them at 1 breath every 6 seconds with a BVM. Same rules apply for 8 breaths per minute or bradypnea. If we see a patient who's only breathing 8 times a minute and still in respiratory distress, you should buy that patient a lottery ticket, because 8 breaths per minute really doesn't provide enough tidal volume and enough minute volume for our patient to adequately carry out the jobs of metabolism and supplying the body's needs. So that right there is the definition of failure. And we're going to ventilate that person as well. 1 breath every 6 seconds with the BVM attached to 100% oxygen. When we assess our respiratory quality, we have 4 possible categories. Normal, well, hopefully. Then we have shallow. What do you think shallow breathing means?
Almost like a gasping.
So kind of, that'll move us a little bit further down the list. Corey, this is probably a good one for you because you asked a question about shallow. What do you think shallow breathing means?
Yeah, this makes more sense. Like not very deep. Like you just kind of
When we look at our patient's chest, what's shallow breathing going to look like?
very
Little
fast.
Yeah, it doesn't really have that much to do with rate. It has more to do with travel. How much does that chest wall move?
Yeah,
So
very little movement.
yeah, we're getting barely any chest wall movement, which means we're not really creating that much of a pressure difference inside the thoracic cavity, and not as much gas is getting in, which means not as much gas is getting down to those alveoli because we're not filling up our lungs appropriately. Now, labored, that's pretty easy. When I look at their respiratory quality, does it look just like too damn much work? It's possible that it does. Should breathing ever look like a lot of work? Does it feel like a lot of work right now? If it does, log off the GoToMeeting and call yourself an ambulance. Poof, you're an ambulance. Labored breathing means just that. Our patient is struggling and working pretty hard to breathe. And then we'll get down to noisy. Breathing, should it ever be noisy? Anybody?
No.
No. Remember, noiseless, effortless, and painless. So noisy breathing tells us that there is something wrong with our patient's respiratory status. Doesn't always, especially at this point in the game, tell us what that problem is, but it tells us that there's something wrong. Here's our normal respiratory rates. Our normal respiratory rates are 12 to 20 for an adult. And now let's compare those again to our neonate. You saw an adult who was breathing 40 to 60 times a minute. Guess what you would be working them with? A BVM. 40 to 60 times a minute as far as respiratory rate goes for an adult. You can bet your last dollar that they are pretty well into respiratory failure, and we need to fix that. Being rate dependent though, neonates and babies up to 1 month of age, that 40 to 60 minutes is very, very important to them. That 40 to 60 times a minute is really what's going to keep them a normal, healthy, functioning little kiddo. Now, some of these should look pretty familiar. These sounds can all be audible with or really without a stethoscope. Even some of those ones down the bottom, wheezing particularly. Our asthma patient, when they're really ill, we may hear audible wheezes as we approach them. And that means they are really very sick. Snoring, well, we know what's causing our obstruction there. That's going to be the tongue. We're going to fix that with an OPA. Gurgling we talked about as well. Gurgling is going to be fluid in the upper airway, and we know how to fix that. We're going to apply some suction for 15 seconds on the way out of our patient, suctioning no further than what we can see. Then we have stridor and crowing. It's going to be a partial upper airway obstruction. Crowing is normally heard on expiration. Stridor most of the time is heard on inspiration. It means there's constriction. There's some sort of partial obstruction in the upper levels of the airway. Wheezing is going to be constriction or narrowing of the bronchioles. We're going to have a reduced internal diameter that's going to make it difficult for your patient to get gas out, and we're going to hear that wheezing sound. Crackles means your patient has too much fluid on board and it is surrounding the alveoli. Remember, that alveolar capillary membrane, that oxygen is supposed to go from the alveoli and diffuse across that one cell wall to get onto the hemoglobin. Now we have that alveolar capillary membrane that isn't just one cell wall anymore. It's one cell wall, and then it has to go through a river in order to get into the capillary bed and actually attach to that hemoglobin. So we'll hear this sort of popping sound when we listen to this patient's chest, and it's because there's fluid in the airways. And then the last one, bronchi. This is just mucusy, sort of junky sounding. It sounds just like you would think that it would. It's when your patient has some sort of infectious material or something like pneumonia or bronchitis, and there's just a whole lot of crud down in the lower structures of their airway. And it sounds sort of like rumbling and like it sounds if you yourself had a chest cold and was coughing up a whole bunch of lung butter. So skin color, temperature, and condition is important. Skin color, temperature, and condition is something that we begin to evaluate right during our primary assessment, because that is just the absolute fastest way to take a pretty good quick look at our patient's perfusion status and know whether there's a problem or not. People, general rule here, and it pretty much holds water, should be pink, warm, and dry. If we see a patient who is not, if we see a patient who has some cyanosis or has some pallor, so they're kind of gray looking, or mottled, their skin just looks blotchy and kind of gross looking, or they're cool to the touch or hot to the touch, or we see somebody who is just either sweating profusely sitting at rest, or we see someone who maybe is a bit dehydrated and their mucous membranes look like we could strike a match on them. Those are abnormal findings for our patient's skin color, temperature, and condition, and they lead us towards, is my patient having some perfusion issues? Is blood not getting circulated appropriately? Is their fluid status in question? And it really helps us figure out quick and fast and pretty much a down and dirty look at how well or poor is this patient doing right now without ever really even putting a hand to them. Best places to do this assessment is going to be our nail beds, the inside of our cheek or inside of the lower eyelids. Like I said when we were first talking about vital signs, regardless of someone's skin pigmentation, these places should pretty much be pink, warm, and dry. As far as the mucosal membranes, we'll use a little bit of common sense there. And if they're called mucous membranes, so the inside of the eyelids or inside of the cheek, we don't want those to be bone dry, but we also don't want to look inside our patient's mouth and see them salivating uncontrollably. If skin color, temperature, and condition looks normal, we'll call it normal. If it doesn't, because now, all right, the inside of their mouth looks like they were just trapped in a sandstorm and their mucous membranes are just completely and totally devoid of any fluid, that's a significant finding. If we look and we see changes in color like any of these, so pale, that general look people get when they're sick. Cyanosis is that blue-gray color. We would probably couple our assessment of someone who's cyanotic with poor rate, rhythm, and quality, and maybe bad lung sounds on our respiratory assessment in their vital signs. Or we see somebody that's flushed because they were just stung by a bee and they're allergic to bees, and we see reddening of their skin because the initial response to that anaphylaxis is to dilate all the vasculature, and I mean all of it, so blood will be forced and kind of rushed out to the skin initially. And then we have jaundice. Jaundice is a yellow patient we see a lot of the times with patients who have some pretty advanced liver disease. It is really just their liver is not functioning well and they are pretty sick. Skin temperature, that's fairly easy. We're going to take the back of our gloved hand, so you'll peel off just the back of your glove a little bit. We're going to put the back of our hand against the patient's forehead or against the trunk of their body. And we want to know, do they feel very, very warm to the touch or do they feel cold to the touch? People, when we touch them with the back of our hand, we shouldn't really feel much of a difference. If your patient has a fever significant enough to feel hot to you, that means they probably have a pretty significant medical condition going on. And the same can be said for if when we touch our patient, they feel ice cold, well, it's also a pretty safe leap to make that our patient is pretty sick. When we talk sepsis and septic shock tomorrow, I'll tie that together a little bit because that video first said that, you know, your body's initial sign, job to fight an infection is to raise body temperature. That's because bacteria don't live particularly well outside of very, very defined temperatures. But once that safety mechanism, once that compensation starts to fall off, our patient goes from feeling too hot to now feeling like we just pulled them out of a refrigerator. And we can see some other systemic changes that make us decide this patient not only is sick, but they have gone through the stage of where their body is still putting up with the insult. Did all that. Pupils we already covered. Make sure the environment is dim rather than bright, and it will give you a much better understanding of their pupillary response. It is entirely possible to check someone's pupillary reaction, say, out in the bright sunshine. But at that point, are we going to shine a pen light in their eye if it's, you know, noontime on an August day? Do you think that will elicit any change? Yeah.
No.
No, you just let the sun do it for you.
Yeah. And my pen light's not brighter than the sun, so I'll cover both eyes and move one hand. When I cover their eyes, it's going to provide a dim environment for their eyeball, for their pupil. So when I cover them, I make sure I'm not letting too much light in. And when I move my hand, I'll watch their eye constrict. So it'll go from dilated a little bit because I covered it up and made it dark to now it's bright and we'll watch that pupil constrict. So, you know, it's based on where we're working on this patient and where we're doing our assessment, but we need to provide ambient light changes to both eyes at the same time in order to make sure that we're getting a good assessment.
My brother and I's, we have blue eyes, and we both have like huge pupils all the time, and I have no idea why. Like obviously in the sun they get smaller, but my pupils are always my eyes look black a lot of the time. It's like people like always comment on it.
And I
Like,
mean, really, what's normal for you is normal for you. It doesn't make that much of a difference. Pupils,
Yeah.
when they're big like that, are just letting more light in.
Yeah, because like I mean in the sun they like my pupils get smaller, so does my brother's, but like they're always like pretty big. Otherwise.
That happens. I have to go to the eye doctor like all the time, and every time I go there, they dilate my pupils, and I walk around till the next morning with eyes that look completely black. It's not a rocking good time. So here's our definition, right? Constricted pupils up in the upper left-hand corner there are pupils that are very, very small. Dilated pupils, well, all right, we're going to operate in the vein of common sense here for a minute. Dilated means too big, so those are pupils that are bigger than what we would consider normal. And then we have unequal. So let's talk about what all that stuff means. Dilated pupils especially if they are fixed and dilated, means our patient's probably in cardiac arrest. That means there is no blood flow to the brain, no CO2 removal from the brain, and the brain is not doing particularly well, and neither is the rest of the patient. If we have pupils that are dilated but still reactive to light, generally that means some form of drug intoxication. But again, and Corey, you gave me a great segue to this, put it together with the entire picture of what we're dealing with this patient. You know, did we get called for an emotionally disturbed persons or an EDP? And when we show up, our patient's eyes are just almost completely black. They react only a little, but they do it quickly, and they are acting like a complete and total maniac because they've been smoking crystal meth for the last 6 days without any sleep. Okay, well, that kind of points me towards why their pupils are so dilated. And they're clearly not in cardiac arrest because they're running around like Superman. Constricted pupils are going to point us towards a central nervous system disorder or something maybe along the lines of narcotic use. If we have problems with the central nervous system, those pupils are going to get really, really little. And then we have unequal. Unequal is really to the point of about as bad gets. You know, most of this other stuff we can work with. You know, a patient who's in cardiac arrest, we do CPR. A patient who's using drugs, we try and work our way through all of that. Unequal pupils combined with something like a stroke, a head injury, or significant trauma to the eye are some things that are gonna really point us at this patient is critical. This patient is not doing well. The brain has to be affected pretty significantly, whether it's trauma, whether it is a stroke, to actually cause those changes to the pupil and have really only one side of the brain affected enough to make that pupil response abnormal, that this patient is significantly ill. Some other things that can cause those unequal pupils, if we have obviously an artificial eye, that pupil is not going to dilate and contract. It would be a good thing to get during our sample history, and we'll talk about that in a few minutes. But does your friend here that's unresponsive on the ground have any medical conditions? Oh yeah, Hank's got a glass eye. All right, well that rules out why the pupil didn't respond when I shined my pen light in it.
You know how when not to like keep interrupting you, but you know how like when your friend or somebody that you know is like super drunk, is that like does that count as an unequal, like in their eyes like separate? And obviously we're gonna go to cases like that where someone's like, you know, really drunk, but like does that mean that their eyes are unequal, or does that have to do with the pupils? Because sometimes your looks like people's eyes separate and like
Oh yeah, that's not so much pupillary response. That's more central nervous system and fine motor control,
yeah,
because your body's supposed to keep your eyes focused in the same manner all by itself.
yeah,
It's more the result of the depressant effects of alcohol and being really sort of wasted than it
yeah,
is a pupillary thing.
okay.
So our non-reactive pupils, again, we're talking cardiac arrest or brain injury, drug intoxication, overdose. So when we show up, they could be constricted, they could be dilated, it could be any mix of the two, but we're going to shine our pen light into our patient's eye and no change happens. Nothing takes place. It looks like we got a video.
Hi, I'm Josh Farquharson, and welcome to Blood Pressure Audio-Visual Coordination Skills. There are several steps involved in taking a blood pressure measurement, and each step must be completed with accuracy. This is especially true when viewing the blood pressure dial and listening with the stethoscope. You must be able to effectively coordinate what you're hearing with what you're seeing. Just imagine if you recorded a patient's blood pressure as normal, when in actuality, their pressure was extremely high and they were at risk for having a stroke. your inaccuracy can have dire consequences on the patient's overall health. This lesson will help you achieve accuracy when taking blood pressure measurements. By the end of this lesson, you will identify and interpret the graduation markings on an aneroid sphygmomanometer dial, and determine the systolic and diastolic blood pressure by reading the dial and listening to the Korotkov sounds. If you ever had your blood pressure taken, you likely noticed that the results were stated as one number over the other number, such as 120 over 80. The number on top, in this case 120, represents systolic pressure, and the bottom number, in this case 80, represents the diastolic pressure. Let's take a close look at the dial used for determining such a measurement. This is the aneroid sphygmomanometer dial, also known as the blood pressure dial. The dial has the letters mmHg because blood pressure is measured in millimeters of mercury. Also on the dial, you'll notice that there are lines in various sizes. The largest lines represent values of 20. This is 20, this is 40, 60, and so on. The medium lines represent values of 10. This is 30, 50, 70, and so on. And the smallest lines represent values of 2. So this line represents 22, 24, 26, 28, and so on. Now let's use the needle to determine the number displayed on the dial. Concentrate on the tip of the needle and the line that it's pointing to. How much does this line represent? If you stated 68, you are correct. So how much does this line represent? If you stated 112, you are correct. And how much does this line represent? If you stated 294, you are absolutely correct. Great job. Now that you're comfortable with reading the blood pressure dial, let's apply audiovisual coordination skills. And for this, please increase your volume level and have a pen and paper on hand. There are two main areas that you need to focus on when determining a blood pressure reading. One, the position of the needle on the dial, and two, the Korotkov sounds. We will refer to the Korotkov sounds as thumping sounds for the duration of this video. When you arrive at the point of the procedure, when you slowly deflate the cuff to hear the sounds, you will notice the needle move in a counterclockwise direction. It is at this point that you need to listen very closely for the thumping sounds. Upon hearing the first thump, note the needle's position on the dial and record the number. That's the systolic pressure. As the cuff deflates and the needle continues to move, you will continue to hear the thumping sounds. Listen closely for the last thump. Upon hearing the last thump, note the needle's position on the dial. That's the diastolic pressure. Let's practice applying these two steps. Please note that your answer may be slightly different from what's displayed, but that's okay. As long as your answer is within 4 millimeters of mercury, your answers are still considered accurate. For example, if the displayed answer is 120 over 80, but your answer falls somewhere in the range of 118 over 78 through 122 over 82, your answer is still considered accurate. Of course, matching the displayed answer is the goal to achieve the most accurate answer. We'll use 114 over 76 as an example. All right, so now that you know the basics, let's try a few simulations. Listen closely and write down your answers. I will reveal the correct answer once the simulation ends. Here's the first one. Try another. Okay, and let's try one more. So, did you answer all of them correctly? Great job. Give yourself a huge pat on the back for a job well done. There's so much more to learn about blood pressure, especially when it comes to the terminology, ranges, and the many steps involved in the process. Continue to discover, review, and practice as much as you can to master the art of measuring blood pressure correctly. And there you have it. You have learned to identify and interpret the graduation markings on an aneroid sphygmomanometer dial, and determine the systolic and diastolic blood pressure by reading the dial and listening to the Korotkov sounds. To stay up to date on other... Hi, I'm Josh Farquharson, and welcome...
All right, so we're all at least a little bit familiar with what we were just talking about there. Change is more significant in measuring a patient's blood pressure than just one measurement. I hope that's something that we are taking home from this lecture. Changes in vital signs are definitely bigger business than one reading all by itself. Normal blood pressure, remember that is, again, normal with air quotes, is going to be no greater than 120 systolic over 80 diastolic. There's a litany of things that go into what makes a patient's blood pressure go up and what makes a patient's blood pressure go down. But this is generally what is considered to be average for people of a normal health. So we don't do a whole lot down to, 1 to 2 years of age in toddlers, but just know that the further down you go, so adults, we're looking for 120 over 80. The further down that list we travel, the lower the patient's blood pressure is going to be. We should still see, pink, warm, and dry skin. We should still have a nice brisk pulse. We should still see that rapid and fast rate, capillary refill time come back. So we want to make sure that all of these things line up. Well, we've gone over this and we'll go over it some more, and I can assure you that we're going to take plenty of blood pressures, but the cuff, we want it to cover the up 2/3 of the upper arm. So it's going to go between the elbow and the armpit. We're measuring it with a sphygmomanometer and a stethoscope. That is blood pressure by auscultation. Remember, I did say that if you were having a hard time picking up the sounds, it is okay, at least initially, to check a blood pressure by palpation. That's not going to give us that 120 over 80. That'll give us just the systolic number. It's a little less accurate, but any port in a storm, really, if we need to get a quick blood pressure and we can't hear anything because we're on the highway or at a fire scene and there's sirens and noise and all sorts of things going on, okay, so be it. But that also will tell us where to start looking as well. Because if we are checking by palp and we come up with a number of 124 by palp, the next time we take that patient's blood pressure and it's a bit of a quieter environment, we know to start looking just before, 124. We really start listening hard around 130 for those Korotkov sounds and blood passing by our stethoscope in pressure waves, and that's a Korotkov sound. And we'll start to be able to pick up the blood pressure a little bit more successfully. We're going to wrap that cuff around the patient's arm pretty tight. We want it to wind up probably about 1 inch above the patient's crease of the elbow. We want the center of the blood pressure cuff over our patient's brachial artery. Remember, we can palpate those arteries and start to feel a pulse before we blow the blood pressure cuff up, so we'll know where to put our stethoscope. As we're inflating that blood pressure cuff, we're going to listen, and we listen and listen and listen, and eventually we will hear Kortikoff sounds. We will hear that pulse, and we pump the blood pressure cuff up until that pulse goes away. And we give it a couple more pumps just to be sure, and we slowly open the valve to let that pressure off, and that air will start leaking out. And then we're listening on the way down, and we're going to listen for when we hear that pulse sound return, when we hear those Kortikoff sounds again, and that's going to give us our systolic number. And then we're going to still slowly let that blood pressure cuff deflate and deflate and deflate, and those Kortikoff sounds will get louder. And then they'll start getting softer again and softer again and softer again until they eventually go away as well. Whatever number is on the dial, when we see those blood pressure sounds go away and those Kortikoff sounds stop, that's their diastolic number. That's that bottom number we're looking for. Let's see if there's anything else. I hope I know how to explain to you guys how to take a blood pressure. So I think we probably beat the PowerPoint. Be sure to use an age and size appropriate cuff. You know, a big giant thigh cuff that would wrap around our pediatric patient twice is probably not really advised to be used for a patient who's 2. All of our trucks will have the appropriate pediatric equipment. So make sure that if you're going to take a blood pressure on a pediatric patient, we use pediatric equipment. So we don't carry thermometers. And with all that's going on as far as COVID and temperature being a really, really important thing, I won't even get into the debate of whether we should or whether we shouldn't. We can still tell a patient's temperature when we do our skin color, temperature, and condition. Let me ask you guys a logical question here. If you put your hand on a patient and it feels like you could cook over them, are they too hot and do they have a temperature?
Yeah, probably a little bit toasty.
Yeah.
Yeah.
And if it feels like you could use your patient to chill a drink, are they probably abnormal on the temperature reading?
Yep.
Yeah. A lot of what we do can really be broken down into common sense type things. We don't need to come up with a number to feel like, hey, I could fry an egg on this patient. They feel like they have a temperature. Add that now in with your patient's chief complaint of, you know, difficulty breathing for a period of a couple days, and you checked your lung sounds and you hear that rhonchi rumbling and making all sorts of noise in their chest. And it's pretty easy to say, this patient probably has some sort of respiratory infection. Now we start looking for signs and symptoms of that septic shock as well to make sure that, all right, this is just your average everyday shortness of breath and possible pneumonia, versus this patient now has been so sick for so long, they're septic and hypotensive and tachycardic, and we start to see skin color, temperature, and condition changes. And now we have put our whole picture together and realized they are hypoperfused as a result of being septic from that same respiratory condition that we were just looking at. So this is where I kind of have to draw a line for you guys. I need you to remember these next couple of words because it's going to be part of your state exam on the practical side. In class, when we do our ABCs, our primary assessment, and we get to B, our breathing, every single patient, once we verify that their breathing is adequate, so rate, rhythm, and quality are good, they've passed the inspection, palpation, and auscultation portion, we put oxygen on them. Non-rebreather mask, 15 liters per minute, period. Every single patient. And then when we get out of class, and even when we're sitting in front of a computer taking tests, we treat people with oxygen when they need it. Remember my trip up onto my soapbox the other day when I was talking about oxygen as a medication and how too much oxygen is not benign like we used to think that it was. So we have stopped in the field and as medical providers over oxygenating people. So your written exams reflect that because they are written to national standard. Also remember that I told you that the Massachusetts State Practical hasn't been updated in 20 years. So you're still going to put oxygen on every single patient with a non-rebreather mask set at 15 liters per minute. Does that, other than drive you completely and utterly stark raving mad, does that at least make sense to everyone?
Yeah.
Okay.
Yeah, so in the test, it's gonna be like, what's the question gonna be like? Is like when we do get that kind of question, what kind of
So
how would it be
on
worded?
a written exam, it'll look something like this. Your patient is complaining of mild dyspnea, shows some increased respiratory effort, has diminished lung sounds, and an O2 saturation of 92. What type of oxygen equipment would you apply to them? And then it will say, you know, 2 things that you've never heard of, or it'll say a non-rebreather mask set at 15 liters per minute, or a nasal cannula beginning at 2 and titrating to effect. Old way of thinking would have been non-rebreather mask, we blow as much oxygen into them as humanly possible. Now what they want on the written is that 2 liters per minute via nasal cannula titrated to effect. Because we know that oxygen in excessive amounts is bad for people. So as providers, we cannot treat them that way. But the state just hasn't caught up yet. So if you were in a practical scenario right then, and you had the exact same patient, and I asked you in person, how are you going to treat that patient? You would say, I would treat my patient with the non-rebreather mask set at 15 liters per minute.
But on the written test, it would be the nasal cannula with 2% titrating to effect.
Absolutely.
Okay.
So the registry is a lot more progressive. They actually do most of the time when there's science updates follow those. Like I said, it's been 20 years since they've changed the Mass State Practical. So when you're taking a book exam or working on a computer, do things that make sense. When you're assessing and treating a patient at the practical exam, do things that are ridiculous.
The test also asks the question whether if you're working in the field and policy hasn't updated, but you know something to be wrong or shown to have killed a patient. I never got the answer to that because the test didn't show me the answers. What is the correct answer to that?
Was this from the module exam?
Yeah.
You know what? I'll look at that when you guys break for lunch, and I'll have an answer for you when you get back, because I need to look at what they gave you for options. Because policy and protocol are two completely like ships passing in the night. They're different things. We can have policies for all sorts of stuff, but unless it's protocol with the book and the state and all of those important folks, policy doesn't hold up over the state. So I will look at that and I'll get back to you. All right, well, we are done our vital signs lecture. I am now going to give you guys a break, and when we come back, we will do medical patient assessment, and we will talk about how we're going to assess every single medical patient from today until the day you guys retire from the field of EMS. Doesn't matter if you are down the road an advanced EMT or a paramedic, or you jump in and out of the back of a med-flight helicopter, the assessment doesn't change. One of the other instructors, he's been a nationally registered EMT and a paramedic for an EMT for over 20 and a paramedic for close to 15. And he still today performs the same patient assessment that he learned 20 plus years ago. So this is something we need to get good at because every patient gets an assessment. But first, a break. So I'll put the timer up here in just a second, and we'll be back in just a few minutes.
Alrighty, thank you.
All right, everybody, welcome back from break. So when we get to this next screen, you're going to see a whole lot of stuff. Don't panic. The medical patient assessment and the trauma patient assessment, they look like they have a lot of steps. They look like they have a lot of moving parts. But what I'm going to tell you is they're both almost completely identical. One's just done verbally, one's just actually done physically. And today we're going to concentrate on assessment of our medical patient. So here we go. Those top two should look very familiar. Our scene size up and our initial assessment. Scene size up is going to be that scene safety, BSI. We're going to start thinking of mechanism of injury versus nature of illness. Then we're going to get into making sure we don't have too many patients that we can't care for them all. We're going to think about some additional resources that may be necessary, police, fire, other EMS, gas, light, whoever. Then we're going to maybe start thinking about some cervical spine immobilization, especially if this was a trauma patient. Once we get through our scene size up and have dotted all our I's and crossed all our T's there, we move into our initial assessment. As we're approaching our patient, we're going to form our general impression. We're looking to see, does this patient look well or not well? Are they responding appropriately? Are they found in a strange position? Do they look like they're positioned in a way to make breathing easier, or are they positioned in a position of comfort that's sort of non-anatomic, curled up on the floor in the fetal position? Those are all things that start making us question our general impression of the patient. We're going to assess our mental status. We're going to do that AVPU scale. Are they looking at us as we approach? Are they only alert to verbal stimuli when I yell, hey, Bob, open your eyes? Bob opens his eyes and looks at me. Then I'm going to check painful. If he doesn't respond to verbal, I'm going to give Bob a pinch on the trapezius muscle, right at the base of the neck where the shoulder muscles and the neck come together. It's centrally located. It's close to the spinal cord. So it's going to give me a good indication of, is my patient so unresponsive that maybe those nerves aren't even functioning? If they're not, I label Bob unresponsive. If Bob is just looking at me as I'm approaching and speaking to me normally, I know that he is alert. Now I need to make sure that he is oriented. So I ask those 4 questions, conscious, alert, and oriented. What are my 4 questions for that? Anybody remember? How about person, place, time, and event? I want to know if he knows who he is, where he is, reasonably speaking, what time it is, and what's going on. If he can answer those questions, we'll call him conscious, alert, and oriented times 4. If he gets them wrong, well, we start subtracting from 4, 3, 2, 1, 0. Then I start assessing my patient's airway, breathing, and circulation. If I find a problem during my primary assessment, I need to fix that problem. So as I'm approaching, I'm looking for that gross hemorrhage, that significant external hemorrhage that I know, holy crap, I need to fix that. Then I assess the airway. What does an airway need to be in order for me to call it patent?
Clear.
Clear is one of them.
Secure.
Secure is another.
Open. I don't know.
Well, you do know because you got it right. Open, clear, and secure. It needs to be available for gas to come from the outside and make it to the inside. That will be open. Clear means no secretions, no fluid, no particulate, no obstruction. And then secure means either my patient's maintaining it on their own, or we're doing a head tilt chin lift and a jaw thrust and inserting one of our airway adjuncts. So once I've figured out my airway status, I've managed all those problems with gross hemorrhage and airway, I can move on to breathing. I'm going to assess rate, rhythm, and quality. I'm going to quickly listen to those lung sounds. It's going to help me assess rate, rhythm, and quality. I'm going to make sure that the effortless, painless, and noiseless portion of my breathing assessment holds up. And at the end of that, I treat. So again, here in class, oxygen, 15 liters per minute by non-rebreather mask. Now I have assessed and treated anything that can be wrong with breathing. And I'm going to move on to circulation. My patient's responsive, I'm going to check those radial pulses. If my patient's unresponsive, I'm going to compare and contrast a radial and carotid pulse. I'm going to check their skin color, temperature, and condition, hoping to find a patient who's pink, warm, and dry. Any deviation from that means I have a circulatory problem. And then if it's a trauma, I'm going to do that sticky test where I stick my gloved hands underneath my patient. If it's a medical and I'm asking my patient about bleeding, cool, I've finished my circulatory assessment, and now I identify my patient priority. Patient's going to be a high priority transport to the closest appropriate facility with an ALS intercept en route. Those are the words that you need to remember. My patient's going to be a high priority transport to the closest appropriate facility with an ALS intercept en route. That's going to tell me and tell the rest of the TAs that you have made your transport decision and you have identified this patient as sick. You've managed all your primary assessment problems, and now we're going to move on to our secondary assessment. So, if we found a problem during our primary assessment, that's going to be a primary problem. Those primary problems need to be fixed as they pop up, as we find them. During our secondary assessment, that's when things change a little bit. First and foremost, we'll talk responsive versus unresponsive. Our responsive patient, someone who's answering our questions and able to speak to us and able to tell us things that make sense, we're going to focus on their chief complaint. I'm going to ask them, probably during my person, place, time, and event of their mental status, so what's going on today? And they're going to relay to me the events. And if the events jive with why I know I'm there, cool, we worked it out. If the patient doesn't answer that question with something that makes sense to me, I will ask them after I make my transport decision again, so Bob, tell me what's going on today. That way I am going to get in my patient's own words what their chief complaint is. Because we could get dispatched for chest pain, and when we show up, Bob says, I just can't catch my breath. Okay, well, that's much different as a chief complaint than my dispatch information that was chest pain. They may lead me back to the same exact place, but I need to hear it from my patient when they have the ability to tell me what their chief complaint is. That's where I start jumping off from. If my patient isn't responsive and they're unresponsive and not talking to me, I'm going to look at physical findings. I start in the beginning at airway, breathing, circulation, right? If I'm managing an airway issue, well, people that are conscious, alert, and oriented and maintaining their own airway don't need me to do anything for them and able to maintain it as open, clear, and secure. So I know that neurologically there's something going on with my patient pretty significant if I'm managing an airway problem. If my patient is got something wrong with their breathing rate, rhythm, and quality, or their effort, or it looks like it's a lot of work for them to breathe. These are all things I can see even in the unresponsive medical patient. And I'm now going to try and figure out with my physical findings what it is that's going on with them, and is there anything I can do for it. So our secondary assessment of our responsive medical patient looks just like this. We're going to get the history of their present illness, and there is a very regimented way that we obtain those things. We're going to get their past medical history. You guys have heard me say the word sample a couple times. That's how the little mnemonic we use to obtain our past medical history, things that have gone on previously with this patient. My focused physical exam is going to be limited to whatever it is that they're telling me. So my patient with chest pain, I'm thinking cardiac, right? Well, I know that the heart and the lungs pretty much operate hand in hand with one another. So I'm going to look at my chest pain patient, and not only am I going to investigate things of a cardiac nature, I'm going to investigate the other body systems involved with that. So I'll start to also make sure that their respiratory status is good, and I'm going to assess any of the affiliated body systems that go along with their chief complaint. Then I'm going to gather my baseline vital signs. What are my baseline vital signs again?
Jumping off point.
Yeah, jumping off point. I don't know what Bob's vital signs are normally. I have no idea what Bob's blood pressure really is until I check it and figure out where we started. When I'm looking for information, I'll take anything that anybody wants to tell me. The patient, their family, their friends, their maiden Aunt Sally, whoever wants to talk to me, I will listen to them. My focus is going to be on the patient. I'm going to try and get as much information from them as I can. If family is able to fill me in, or bystanders or friends are able to fill me in, great. If not, I just get what I can, and then that's what I live with. What does this ask open-ended questions mean?
Let them talk. Like, ask something that just lets them, not yes or no, but just.
Okay, good. I like it. Don't ask yes or no questions. Things that can be answered in one word aren't useful. But instead of saying, is your chest pain dull and crushing? Because they're just going to answer that as yes or no, and they're most of the time just going to say whatever they think that you want to hear. I would say something like, how would you describe your pain? Because again, it really gets it out in their words. They're going to tell me something because I didn't just give them the opportunity to go, yeah, that's it. So asking them questions that allow them, like you said, to just talk and sort of run off with us here a little bit is going to be the best way that I can figure out at least the beginning portions about what's going on with them. Now, my chief complaint could absolutely be why the patient activated EMS, especially if they're the ones that called 911. It might be different if somebody else called for them, but it's really just going to be, what is bothering you the most today, Bob? How come you called for an ambulance? And they'll tell you. It might be very specific. I have pain right here, and they point and put their finger right on it, and it feels like, and they start doing my assessment for me. Perfect. Or it might be something pretty much as simple as, I just don't feel quite right. I don't feel like myself. I don't feel well. When you take a step back from somebody who goes, ugh, I just don't feel well, it's kind of one of those moments where you go, well, what the hell am I supposed to do with that, right? This. This is our HPI, or our history of present illness. OPQRST is how we get those questions answered out of our patient. So onset, what were you doing when it started? This is one of those like, how did this problem come about? Was it slow and building throughout the day? Or were you just sitting at the table minding your own business and bam, chest pain out of nowhere for no reason? It's going to tell us, was this a sudden beginning to this problem, or was it protracted and kind of coming on? The next one, P, there's actually two P's, provoke or palliation. Provoke means, does anything make it worse? Palliation means, does anything make it better? You know, Bob, does anything make your pain better or worse today? Quality. We're going to ask them to explain to us what it feels like. Now, a lot of these are pain, right? But it can be a lot more generic than that. Rather than saying, does anything make this pain better or worse? If it's not a painful thing that my patient is describing to me, we'll say maybe respiratory distress. Not necessarily going to be any pain that goes along with that, but instead of the word pain, I'll say, does anything make your breathing better or worse? Or does anything make your discomfort better or worse? Because it's very uncomfortable when you can't breathe. Oxygen's only, oxygen's not important until you're not getting enough. So quality, what does it feel like? Describe to me what this feels like. It may be crushing, stabbing, burning. They may not really have a word to figure it out for you. But we're going to ask the question so that they'll give us some sort of descriptor as to what they're feeling. Radiation, where is it? Point to me. Where does it hurt? And does it go anywhere else? Does it move? You know, our stereotypical book definition of what a heart attack is supposed to feel like is 10 out of 10 crushing substernal chest pain that radiates into my jaw and down into my left arm. So that right there is going to tell me it's got some associated signs and symptoms with whatever my patient's chief complaint was. Then we move down to severity. How bad, how uncomfortable are you right now on a scale of 1 being none, 10 being stepping on a Lego? How bad does this hurt? How uncomfortable are you? And then we get to the last one, time. Now, sometimes people feel like onset and time are sort of the same thing. But with onset, really, we're looking more at how did it come on? With time, I want to know, tell me exactly when this started. And then we move on to our past medical history. Our past medical history is just that. It is a history. It is going to tell us what goes on in our patient on the normal. It'll be initially sort of a recap of signs and symptoms. Now, you guys tell me, what do you think a sign is?
Anything you're observing?
Yep, anything you can see. What do you think a symptom is?
What the patient is telling you.
Yep, I can't see what they're feeling. So a sign is something I can visualize. I can see, are they having adequate chest rise and fall? I can see what their skin color and temperature is and condition is. I can't see their chest pain. So that's a symptom. Next thing I'm going to ask them is about any allergies they have. I'm going to ask, are you allergic to any food or medicine or anything? As much as that might not be hugely important to me, do keep in mind that if your patient continues to deteriorate and get worse, you could be the last person that ever gets to speak to them while they're conscious and alert before we get to the emergency room. And in the emergency room, they're going to provide some treatments. They may wind up in an operating room, and they're going to need to know that your patient is allergic to medication X, Y, or Z because they can't talk to them. So figuring out, does my patient have any allergies, is something that's really, really important. Also, getting a good list of their medications. Now, I don't know why, but it seems like every household in America where a patient is on a lot of medicines, they're kept on top of the microwave. I don't know if that's just a New England thing or what, but that's where they live. So when you're questioning your patient, your partner will probably split off to go start figuring out what they take for pills or what they take for meds. You guys will get to the point where after you've done this for a while, you'll be able to write your patient's medical history backwards from their list of medications. You'll look at their list and go, all right, they have high blood pressure, they have high cholesterol, they've had a heart attack, they have type 2 diabetes, they have this, they have that, they have the next thing. And it is just another thing that not only is important for us to know, but downstream when your patient is receiving that definitive care, because our angle here is to get them to the hospital to completely correct, not just make better, whatever their problem is. Then we ask their pertinent history. Now, when I'm on scene and I'm getting my patient's medical history and I'm doing this sample and I ask what they have for pertinent history, sometimes your patient will start, back at the dawn of time and talk about the appendectomy they had when they were 8. And, old Doc Johnson came to the house and took the tonsils out of all the kids back in the 60s. And it just goes on and on and on and on and on and on. Do you think that's what I'm looking for here?
No.
No, you're looking like if they might have had cancer previously or just serious surgeries within the last like 5-10 years.
Even a little bit shorter than that, I'm looking at things that are pertinent to what's going on right now.
Right.
If I'm there for a respiratory distress, your pertinent history would include things like asthma, emphysema, COPD, chronic bronchitis, things of a respiratory nature. If my patient's complaining of something like chest pain, I want to know, have you had any heart attacks before? Do you have high cholesterol? Do you have high blood pressure? Because those things are going to start helping me develop my story a little bit. Now, when we get to the ambulance and we're transporting and I'm doing my reassessment and you want to tell me all about, good old Doc Johnson coming to the house and cutting tonsils out, great, I'll take it. But when I'm trying to figure out what it is that is made you so ill that you had to call 911 right now, I want to know what's pertinent to right now. The LN sample stands for last ins and outs. So last oral intake and last time your patient used the bathroom. Sometimes that's an uncomfortable question to ask, but it is something that most of the time is very, very pertinent. Especially once we start talking, geriatrics and pediatrics. A decrease in urine output in a pediatric patient because they've been sick for, 12 hours can show me a pediatric patient who's profoundly dehydrated. Now, coupled with that, if they've been sick for a few hours and have had poor PO or poor by mouth intake of food and fluid and things like that, again, it starts to build my case for this patient is heading down the path of being pretty sick. And then I'm going to ask about events leading to the illness. This can be things like, what were you doing at the time? What happened to you right around the time where you started feeling sick? This is useful for my patient who has maybe a bee allergy. I was out mowing the lawn and it felt like something bit me, but I didn't see a bee and I didn't see a stinger or anything like that. And now they are swollen beyond recognition and I see hives all over them and I'm hearing some crackles and wheezes and God only knows what else when I listen to their chest. And I have a blood pressure that's in the toilet. And it's a pretty easy leap to make, like, hey, you probably got stung by a bee just based on the events that were leading up to you getting sick. Now, add to that I'm going to ask all the rest of the OPQ-RST questions, like, how did this come on? Well, it was sudden. Does anything make it better or worse? No. Can you tell me what it feels like? I'm itchy all over and you'll hear the stridor. and they'll be complaining of maybe some tightness in their chest. Well, okay. Does it go anywhere? No, it feels like it's everywhere. Okay, that's systemic. How bad is it? And they'll say, this is about an 8. This is worse than the last time I got stung by a bee. And then you'll see the light dawns on Marblehead, and the patient goes, ah, crap, I got stung by a bee. This jerk's going to stick me with an EpiPen. Facts. So these things all tie each other together. So even though they might seem a bit repetitive, they're there for a reason. And then last but not least, when we're talking sample, the new terminology for that is sampler. Do they have any risk factors? Are they obese? Do they smoke? Do they drink too much? Are they a drug user? Do they have a family history of, their first degree relatives that died at the age of 35 from cardiac disease or stroke? And now they're presenting to me at 35 with signs of cardiac disease or stroke. Those would be some risk factors. Some of them are controllable, things like smoking and drinking and drug use, obesity. Some of them aren't controllable, like family history and genetics. It's just them's the breaks. We're going to tailor our past history to our patient's complaint. That's what I mean by, don't let them sort of direct the interview. Ask questions that are pertinent to what you're looking for. And if you're looking for, does your chest pain radiate anywhere? And they say no, and point right to the spot where it hurts. That's what's called a pertinent negative. Because remember that book definition, stereotype, classic myocardial infarction is pain that radiates into the left arm and left jaw. And does that mean because there's a specific spot on this patient that hurts, that maybe they're not having an MI? No, but it is a pertinent negative. You asked about radiation, you were expecting them to say yes, and they said no. We're going to look at our body systems that are most likely involved. We're going to include any body systems that are closely related to their chief complaint. So again, our patient with a cardiac complaint, we're going to also check respiratory status. Our patient with a respiratory complaint, we also want to know cardiac and circulatory status. Those things are pertinent to one another and they need to be investigated together. If we're going to be working on a child, kids are their own brand of difficult when it comes to performing a good assessment on a child. Sit down with them, get at their level. It is way, way less threatening than us standing and looming over them like some sort of authoritarian figure or, somebody that they need to be concerned about or afraid of. Use simple language. Don't explain things far in advance. As you're going to do something, explain it to them and use as easy of an understandable language as you can. Kids aren't always, when we do talk about the questioning aspect of this, they don't really have a real good grasp of medicine. Ask the caregivers what's different about the child. Ask the caregivers sort of what's been going on with them today, because kids are going to have a difficult time answering some of these questions. Making the child part of the assessment, that's simple enough. I've let kids take my blood pressure in the back of the ambulance. I've let them listen to my lung sounds. Just remember that kids are very literal. Saying something like, I'm going to take your blood pressure, they immediately feel like you are going to remove something from them. So choose your words carefully. And as far as pediatric patients go, always be upfront and honest with them, because the minute you lie to a kid and say, oh no, this isn't going to hurt, and then it does, they'll remember that and you'll be burned forever. They don't want to hear another word from you because you're the person who lied to them, and friends don't lie. Our physical exam on a medical patient, generally fairly brief. If my patient's got a respiratory complaint, I'm going to look at their chest. I'm going to make sure I don't see anything visually wrong with the chest. That's going to tell me, okay, maybe it's a muscular problem. Maybe this patient was involved in a trauma that they haven't told me about yet. I'm going to listen to their lung sounds. We are pretty much looking to make sure that all of our ducks in a row and all of the areas of concern that have been evaluated. Your focused physical exam is also going to include your vital signs, because the next thing we're going to do at the end of that is obtain our baseline vital signs. Baseline meaning the first set. It gives us our jumping off point. We're going to compare any downstream or any later sets of vital signs to that baseline set. And we're going to note any significant changes, whether they're good, bad, or ugly. If there's a change, we need to say that there's a change and figure out what it is. Because once we've done, all right, we're going to skip through this. We've already just did the vital signs lecture, so we don't need to. We're going to reassess our patient. Maybe we're going to provide some treatment. After we get through the secondary assessment, we do the OPQRST, we do the sample, we do our physical examination of this patient, we get our set of baseline vital signs. That's when we start thinking about those protocols that I handed you guys all on Friday. That's when I start thinking about, do I have enough information to say, yes, this patient needs an EpiPen, and here's what I can use to back that up and make sure it's the right treatment. And then can I apply that treatment appropriately? And once I've applied that treatment appropriately, I go right back to the beginning. First, I'm going to reassess their vital signs after a couple minutes to make sure that my treatment worked and is hopefully doing the things that I want it to do. But then I'm going to start right back at my primary assessment. I'm going to reassess their airway, especially if I had to manage an airway problem. I'm going to reassess their respiratory status, their breathing, especially if I had to manage a problem, and so on right down the list. Now, I might not re-ask OPQRST and sample because the patient will look at me like, wasn't this moron paying attention to me? But I'm going to begin my reassessment by checking the things that I know are going to keep this patient alive. And then I'm going to ask them questions about, hey, since I gave you that medicine, are you feeling any better? And they'll tell me, yes, no, maybe, I don't know. But then I can couple that with some vital signs. I can listen to their lung sounds and see, all right, well, your wheezing is improved and you don't look quite like you're working quite as hard to breathe. And now I know, yes, my treatment did work. Or now, instead of wheezing, I have a silent chest, and I have a patient who, when I went back to my primary assessment, now is kind of somnolent and difficult to wake up. And I'm having a hard time sort of keeping them aroused and keeping them maintaining a mental status. And now I know, all right, well, we were behind when we got here and my treatment has not been successful. What do I do now? If your patient's unresponsive, we're going to get our chief complaint and history downstream. If my patient's unresponsive, I'm going to get a physical exam and baseline vitals right out of the gate. And then I'm going to start working on getting some history from bystanders or family or anybody that's with them. I'm going to do a rapid assessment of the body from the head to the toe. I'm going to touch, inspect, palpate, auscultate, everything, soup to nuts, top to bottom. Why do you think I do that?
Just to make sure you didn't miss anything?
That's the answer I was looking for. Absolutely. Now this goes for an unresponsive medical patient. This is the exact same for our trauma exam on a trauma patient. If I start at the head, work my way to the toes, and have poked and prodded everything in between, it's categorically impossible that I've overlooked something. I've assessed the head, the neck, the chest, the abdomen, the pelvis, the extremities. I roll them up onto their side. I check the posterior. I have now examined every single inch of this patient. Could I have missed something? Not likely, because I've gone through all the trouble of doing this assessment. I've looked at the neck. I want to make sure that I don't see any distended jugular veins. I'll show you a picture of what those look like when we talk tomorrow about shock. I'm also going to be evaluating my patient for any medical identification devices. I'm going to reassess their lung sounds and see if anything has changed there. I'm going to palpate those 4 quadrants of their abdomen, looking for distension, firmness, or rigidity. When I get to the pelvis, I'm going to start looking for things like incontinence of urine or feces, because that'll point me towards, all right, well, maybe this patient has a seizure disorder, and that's why they're unresponsive right now. When I get to their extremities, I'm going to check pulse, motor function, and sensation. That's CSM, circulation, sensation, and motor function. We can even do that on an unresponsive patient. You can take your pen or the handle of your scissors and run them up along the base or the bottom of your patient's foot, and you'll see a neural response. You'll see your patient's toes kind of clench and then open back up. That means at least there is some neurological function between the brain and the feet. When I roll them onto the side, I'm going to check the posterior for all of these same things. Now, your unresponsive medical patient is a mystery, but we're still going to check for their baseline vital signs. We're going to request an ALS intercept because this patient is altered. Normal people don't just lay around the house unresponsive from a medical condition. So we're going to go ahead and get some advanced level help to see if maybe one of their monitoring devices can pick up what it is that's going on with this patient. And then I get into my detective work. That quick scan, head to toe, front and back, is really kind of just looking for the obvious. We're trying to figure out in a short amount of time, what is making this patient unresponsive, and is there anything I can do to fix it? Then I start getting into that HPI and the OPQRST and their medical history with sample. I ask their questions. I'm going to ask, obviously, try and get what their name is. I'm going to ask what happened. I'm going to ask the family or friends if they noticed anything about this patient before they went unresponsive. Did they complain about anything before they went unresponsive? Do they know anything about their medical history or any medications that they take? And after I finish that assessment, we're going to go right back to the beginning again. Doesn't matter if the patient's responsive or unresponsive. We're going to go right back to our primary assessment. We're going to go right back to asking them or trying to discern what's wrong with them, or just reassessing any treatments or interventions that we have done in order to try and make them better. It is just, we get to the end of the line, we apply our treatment based on our protocol, and we begin to reassess. We reassess and look at all the things that caused us enough concern to medicate this patient and give them nitro and give them aspirin or give them sugar or give them epinephrine or give them Narcan. And we just work it right from start to finish again. And if our patient is significantly ill, we do it every 5 minutes. That includes vital signs. So it's continuous workflow. We just keep going through and going through.
If you like see somebody, so if you go to a scene and no one's around, it's just that person that, well, I'm sure someone will be around because somebody called for him, but what if you find that I forget what you call like the person that has something that do not resuscitate or do not anything, like would they have that on them?
They may.
But if they don't, then that's not your, like, you still have to treat them.
Right. If they don't, we can't be held responsible for what we don't know. So
Right.
if your patient doesn't have one of those with them and we're not able to verify any of that, then we just work them like we would any other time. And then when they get to the hospital and their family eventually gets to the hospital. You know, whatever happens after that doesn't belong to us, but we can only go based on what it is that we know to be fact.
Right. And like if someone is at the scene with them and they said that do not, like, I mean, I'm sure this probably would never happen, but that, and they say, oh, he doesn't have his, or she doesn't have his card ID that says do not resuscitate, but he or she does not want you to touch them and this and that. You can't take their word for it because it's not fact.
Right.
Right.
Unless you have that physical form right in front of you and you can verify that it is indeed filled out appropriately and legitimate, you have to work the patient, period.
Right. And you say to them like, I'm sorry. Well, or what do you say to a person that's like saying don't touch them or whatever?
While one person's working on the patient, the partner would be explaining to them, like, without the proper documentation, we can't just take your word for it. This would probably be another good time to have other responding people on scene, like police or fire, so that somebody could split off with that particular family member,
Mm-hmm.
because it's going to be upsetting.
Right.
Most of the time, people that have those types of orders and know that they are getting towards the end of life, if they go out with family or something, most of the time somebody remembers to have that with them.
Right.
It's not always, because I have people that I know who have been in that situation and had to work that cardiac arrest, and it stinks, and nobody gets to be happy after it. But it is just one of those things, like, we can't just go, oh yeah, you're right. Nana probably didn't want to be resuscitated. You know, she's lived a good life. Have a good one.
Yeah, like it's just tough because like people that are religious are super, super like not in a bad way, just like a super like really crazy about that type of stuff. You know, they don't if they're gonna go, they're gonna go. Like that's how they think. You know.
Yeah, and most of the time, things like that are pretty well worked out ahead of time.
Yeah.
We don't often run into those kinds of situations, because when somebody is made a DNR, present times excluded, they have to actually sit with their doctor and discuss this, and your family is involved, so
Right.
everybody knows what page that we're supposed to be on.
Mm-hmm.
It is not a super frequent occurrence, which is great because it's miserable when it does happen.
Yeah.
I kind of feel like if somebody was that religious about the whole situation, they wouldn't call us anyway.
Yeah, well, what I can tell you after lots of time with all of this, everybody thinks that, you know, being a DNR or doing hospice care at home, for the most part, everybody's like, yeah, that sounds like a great idea, right up until the point where the process begins.
Mm.
And then it's, oh my God, we can't do this. We need to take Nana to the emergency room right now. All right, well, you just handed me a piece of paper that said Nana wanted to be in her own home. She didn't want to go to the emergency room. Like, you do sometimes have to have that legitimate discussion with people, because when you do things like hospice care at home, you are still working with an agency that sort of is supposed to take care of those kinds of issues. Sometimes people's knee-jerk reaction is to panic and call 911 and think that we're just going to go hauling poor Nana out into the cold, into the snow, into the rain, as opposed to making that phone call that they really should be making to the hospice agency so that somebody will come and help them.
Right.
Because I will argue to the death that me showing up and dragging Nana out of her house into the snow, into the cold, into the rain is not helping her. But I'm also up against protocol and up against the wishes of the family, because then the next thing they'll say is, well, she before she went unresponsive, she said she wanted to go to the emergency room. It's like, all right, well, now I have to drag this poor woman to the emergency room. She goes into cardiac arrest en route. I have to work her. And this isn't really the way that the whole thing was designed, you know, even on scene, something as simple as, hey, do you mind if we call Nana's nurse real quick and just you can have a brief conversation with her while we package Nana up, and then we'll figure out what we're going to do from there. You know, some of what we do is steeped in diplomacy, because we're in difficult spots sometimes. And like I said, I would argue to the finish that snatching that poor old lady up and dragging her out of her house to the emergency room is not in my patient's best interest. And I would feel rotten about having to do it. I've personally been in that situation. I picked up a patient at a nursing home who was at a nursing home on end of life care. And she was as unresponsive gets. Never so much as twitched when we picked the woman up off the bed and put her onto the stretcher. There was nothing going on. She was actively passing away. And that's what the chief complaint was when the nursing home called my ambulance company. And I said, you know, I'm looking at your paperwork here and it says that she's a DNR, DNH, DNI, all the DN everything. And she's here on hospice. The emergency room's going to ask me, why am I bringing this woman to the emergency room? And to be honest with you, I'd like to know too. And the response was, well, she's actively dying. And I couldn't help myself, because the next words that left my mouth were, that's what she's here to do. And the phone call from the nurse actually beat me to the emergency room. They were not happy. But sometimes you do have to be a patient advocate. And that's what I felt like I was doing, because I felt like what I was being asked to do was wrong. So, all right, there's patient assessment, Chapter 9, Part 3 and 4, Vital Signs and Medical Patient Assessment. That seemed pretty straightforward.
Yep, right up till the nurse didn't want to do the paperwork that the patient died.
Yeah, I was not a fan. Neither was the emergency room. They were madder than I was, but that's a story for another day. This gets to be sort of much more part of the way that you do things the more that we do it. So we're going to go through a lot of this stuff over and over and over again and drill it in. And every time we talk about a medical condition, we'll talk about OPQRST, samples, some of the changes in vital signs, and it sort of ties it and wraps it all up in a nice tidy little bow, because it shows us all of sort of the inner workings. And then from there, it'll help you be a little bit more able to react when, since our patients don't read our textbook, they don't exactly know how they're supposed to present. And you go, oh my God, what am I going to do now? And the answer to that is, I'm going to fall back on my training. And once I've gotten to the end of OPQRST, sample, and my physical assessment and my baseline vitals, I'm going to decide whether I can treat or not. And if I can't, I'm going to go right back to the beginning, and I'm going to start primary assessment, making sure my patient's condition hasn't changed, making sure that they are still the same brand of sick that they were when I got here. And if I can treat them, I'm going to make sure that I have the right patient, the right route, the right medication, the right dose, the right time, the right documentation, and the right indications. I'm going to treat their condition, and then I'm still going to go right back to the beginning and start right at my primary assessment and make sure that now my patient's condition is improving, not getting better, and the medication that I just provided them is doing the things that I expected to do inside of their body, and that, holy buckets, I just made this patient better. And then we just keep doing it every 5 minutes because your patient's sick.
And you said it's sample with an R at the sampler now, right?
Yep, we're looking for those risk factors. And
Okay.
if you remember that, great. If you don't, also great. That's not hugely important. So, all right, that's the show for today. I'll see everybody at 1 o'clock. I am headed back to my computer to do some work on EMS testing. Malachi, send me an email about that question you had and I'll look into it. And I'm gonna reopen some things and I'm gonna go ahead and give second attempts on some stuff.
Thank you.
Now that you guys have sort of had a look at the monster, you'll be probably much better suited to answer some of the questions that you got wrong.
Yeah, there was one of the, I don't know, remember which homework it was, but I kind of screwed the pooch on it. So I'll
Hey,
try to
it
figure out
happens.
which one that was and let you know.
Yeah, I'm gonna go look at it anyway. I didn't have time this morning.
Does the homework count as far as grades?
Everything counts.
Oh man. Okay.
All right, I'll see you guys all soon.
All right,
All right,
thank
thanks.